Bene, allora continuiamo la sessione. Purtroppo il tempo stringe, ma credo che è importante poter dare un po' di tempo per le domande. Probabilmente dovremo prevedere più tempo nelle prossime occasioni. È un gran piacere introdurre il dottor Paul Myres, che ho avuto il piacere di conoscere ieri. È presidente dell'Accademia del Medical Royal College e responsabile della qualità del Royal College of General Practitioners del Galles. Per 30 anni ha lavorato come medico di base nel nord-est del Galles, dove ha ricoperto diversi ruoli nel campo dell'insegnamento, della conduzione degli audit e nel miglioramento della qualità, nello sviluppo delle cure di base e nel management delle cure. Allora un piccolo aneddoto, perché visto che sentiamo diversi aneddoti, anch'io porto un piccolo aneddoto. Ieri parlando mi dice sì, il Ticino probabilmente sarà più o meno come il Galles, no? 3 milioni di abitanti. Ho detto guarda, siamo grandi però non proprio ancora così grandi, cresceremo. Lui coordina il Choosing Wisely Galles ed è membro del comitato del Choosing Wisely britannico. Grazie, dottor Myres.
Thank you, buongiorno. And it's a real pleasure for me to be back in this beautiful city of Lugano. I was here 2 years ago, and it's great to be speaking to a multi-professional organization as we realize that choosing wisely is much more than doctors talking to patients. Yes, I represent Choosing Wisely Wales. It is closely affiliated with Choosing Wisely UK, and I'd like to assure you that there are many of us in the UK who still see the UK as part of Europe. And we would like it to remain that way. I think we're probably not going to get our wish, but certainly there are a lot of us in the health services that have some very genuine and real concerns about the direction that our government might be taking us in the UK in relationship to Europe. And I'm very grateful to some of my colleagues in Choosing Wisely UK for some of the slides that I'm going to show you today. What I'm very keen to do today is to focus on the conversation Wendy mentioned about conversations. We in Wales are very much focusing our Choosing Wisely work on looking at the way clinicians and patients make decisions together. So today I'm going to be talking about shared decision making, the need for honesty within those conversations, and the need for honesty when we look back and say, are we genuinely doing shared decision making when we have interactions with our patients? Because we are looking for a culture change. We need to move away from the traditional model of healthcare, particularly probably medicine and nursing, where you've got the doctor looking very formal, talking down to a patient, and really telling the patient what to do and what's in their best interests. And the patient just saying, yes, sir, of course, I will do that. They may not do that, of course. And I'm asking who's in charge? Who should be in charge? Who is the most important in that consultation? Is it the clinician or is it the patient? And you notice in this particular diagram, there's almost a reversal of roles where the patient is sitting above the clinician. We know that mistakes are regularly made in so many consultations because of this difference. The patient comes in unaware of what might happen to them, unaware of what the options and what the various management strategies might be. The clinician is also there in the position of ignorance because the clinician does not really know what the patient is wanting to get out of that consultation, finding out what's important. And if we each don't understand the other's point of view, we're going to get poor decisions that may not be completely right for either party. So we're advocating that if you have better conversations, and notice I'm saying better, not perfect, we're not aiming for perfect, you will get better decisions, and better decisions we know leads to better outcomes. And the useful side effect of those conversations is that you have less waste and more value. So over the next few minutes, I want you to think about the conversations that you've had, either as a patient or a consumer, with your clinician, or if you're a clinician, think about the conversations that you've had with your patients recently. Just to get an idea, can I see how many clinicians do we have in the room? If you could just raise your hand to get an idea. How many clinicians? Okay. Just keep your hands up. Keep your hands up, please, for a moment. Okay. Now, remember the honest bit in my opening slide. How many of you think that you are good at shared decision making? Yes. Okay. I'm not going to make a judgment on that. Other people might make a judgment. Okay. Those of you who have been a patient, so if you're happy to share this, I appreciate you. You might be keeping a secret from the person next to you that you've never been ill in your life and you'd have to reveal it now. But those of you in the last year have had an interaction with the clinician. Could you put your hands up, please? Okay. I don't believe that. Really don't believe that. Most people have some sort of interaction. Who's been to a pharmacist? Most people. Okay, put your hands up if you've had an interaction with the clinician. Okay, thank you. And how many of you felt you were involved in the decision that was made, significantly involved? About half. Okay, and that seems to tie in with what we know. Okay, so a European study, and I don't know whether it included people in Switzerland, found actually that 1 in 3 patients felt they were not given sufficient information about what was going to happen to them. So that's a very big number. But even more, nearly half said that they were not really involved in decisions. So when I go around talking to various professional groups, and I speak to all sorts of clinicians from different, I normally ask them about their choosing wisely experience. A lot of people say, oh, I do it. I do it. You don't need to tell me how to do it. I really do it well. Actually, patients are telling us this is not the case, that they're really not feeling sufficiently involved. So there is a need for a culture change. And one of the things, as Wendy pointed out in one of her opening slides, was clinicians often think they know what patients want, that they know what's important to patients. And this is a slide on patients perhaps choosing when they've got a breast lump what to go for in terms of surgery. And you can see the dark purple is what the providers, which are probably going to be surgeons, they might be cancer specialists, nurses, think that the patients will choose. And that the paler one shows what is important to patients. And you can see there's quite a mismatch there between those. So actually, as clinicians, even though we may all be patients at some point in our life, we do not really know what is important to patients, which is why it's going to be important to ask. So here's a definition about shared decision-making. Clinicians and patients working together, and together is a really, really key word, to select tests, treatments, interventions of any sort, based on clinical evidence. That's really important, that we're upfront with patients, and patients understand what is supported by evidence and what is not, and the patient's informed preferences. So here we are, we have 2 experts. The traditional relationship, I would put it to you, was you had the doctor, for example, up here, who's an expert in diagnosis, an expert in pathology, an expert in drugs or surgery or technical interventions, and who in some ways is the way into healthcare. You have a patient who is anxious, is experiencing something they're not sure about, is unwell, may very well have a traditional view of looking up to this individual. And you have a very unbalanced conversation and a very unbalanced power structure. The power is used to rest. And what we're saying, actually, you've got a meeting of 2 experts. Yes, this person is an expert in diagnosis, an expert in treatment, etc. But this person's an expert in their own life and in the people around them, in their work and their environment. And actually, what we want to move towards is much more a discussion between 2 experts. It may never be exactly equal, but it can be more equal than it has been traditionally. So we would agree, I hope, that those are the experts that the clinician should be putting into this conversation. And that's what the patient is bringing into the discussion. And those are equally valuable and equally valid. So why isn't it happening? There's deep suspicion, including of the Choosing Wisely movement, and all of us who've been involved in the national programs have come up against this suspicion or skepticism from individuals that I hear what you're saying, but basically this is all about saving money. This is all about denying me care, or from the clinicians, this is about denying me the right to give the treatment that I think that's right for patients. So that's one very significant suspicion. There is overconfidence. I do come across clinicians who think, I'm really good at it, Paul. Don't start telling me what to do. I've been seeing patients for years and years and years. I'm good at this. Possibly. There is still an attitude in the UK, and I'm sure it's not confined to the UK, this whole idea of clinician knows best. You're a clinician, you've gone through endless amounts of qualifications. I'm just a humble patient. I don't know anything about my body. You're the expert. Wendy also mentioned this fear of being sued, that litigation is such a problem that if I allow the patient to make the wrong choice, wrong by the clinician's point of view, something goes wrong, I'm going to get into trouble. Does it take time? Yes, it does take time. These conversations will take longer than before. And often we realise there just isn't time in busy consultations. I'm a GP. When I started general practice many, many years ago, we had 5-minute consultations. So usually I was writing the prescription before the patient came through the door to make sure that it was finished on time. Now we have 10 minutes and we're moving to 15 minutes. A lot of people need half an hour. Sometimes there just isn't good information to help doctors and patients make decisions. We're driven sometimes by targets. Our employers want us to do so many hip operations, get so many blood pressures recorded, get so many blood pressures below a certain target, get so many people on statin therapy, that often we're driven by ulterior motives. And there are a lot of people who think shared decision-making doesn't work, so what are we going on about it? So let me suggest to you that in the consultation, and let's just focus on the consultation, okay? We have a patient and a clinician. There may be a third party, there may be a relative, and you need to think, how do you bring the relative into this discussion? So you have there a clinician with their experience and the knowledge. They've undertaken examination, so they do have unique information to share with the patient. They have their own experience. You have a patient who has their history, their personal experiences, what they want out of life and what they want out of healthcare, and both of them have access to information. Sadly, that information is often not the same. Wouldn't it be nice if actually we were quite open and honest and we used the same information, so there was no suspicion on either side that other people had information which the other didn't have? And ideally, in a perfect world, if every decision would be in there. So the clinician is satisfied that that's the right decision, the patients are satisfied with the right decision, and it meets the evidence. So the perfect example is trying to get every decision in there. That won't always happen. We may sometimes have to be happy with 2 things right. But this is where the decisions need to be made, in these areas here. But there are external influences. Occasionally, what's good for the individual may not be good for the public. So particularly in our communitarian healthcare system, if we spend a lot of money on a drug for one patient, that money is not available for anybody else. And if one mother chooses not to immunize her child against mumps, measles, and rubella, and sufficient numbers don't get that, then the herd immunity drops, and we begin to see these infections coming back into the public. So the public good may also be something that comes in and interferes with that shared decision-making, and also the requirement to make best use of money. But there are other people involved with this. It isn't just the health practitioner or the patient. There's the healthcare organization, and they've got an influence on that decision, and they can also distort the decision-making. So for the patient, they're informed by what they've read in the media, what the friends have told them, and the family. They may be influenced by the family. Oh, you should get this done. And family think they have the best interests of their loved ones at heart, but that may not always be the case. And of course, the media also has its own agenda. The health practitioner, the health or social care organization is also influenced. It may not seem the kindly body looking after its population that it's meant to be doing. It may have specific requirements on the government to deliver certain government priorities. It also may need to make a profit or have other business interests. So its opinion might be distorted. So it's its opinion valid or not. And then finally, the health practitioner, it will depend which journal that practitioner reads, or which magazines, or which pharmaceutical representative has just been to try and persuade them to take their drug or influence them in some way. And finally, they also have their own targets. So we have to recognize that the influences are there. So again, is the real honesty in the shared decision making, or are we all in some ways distorted by external influences? And how do we manage that? Can we be open about that and tell our patients when other things are influencing us? So, in terms of making a decision, people sometimes say, but there is only one treatment for this, there is no choice. There is always a choice. There's a choice to have the treatment or not to have the treatment. And hopefully, there's always more than one choice. So, first of all, we need to explain to our patients that there's a choice, because a lot of patients don't realize that. Then we need to describe what the options are in a neutral way as possible without our own personal bias. Not easy. And then we consider those options together. We look at them, the benefits and the risks, but we do that in relationship to what's important to the patient, what matters to the patient. And then we try to make a joint decision. And I'm in an ethical group that's sort of looking at shared decision making. And the conclusion of the group is it's very difficult for two people to make a decision. At the end of the day, it is normally just one person that makes the decision. And also, how can we really be shared and honest when there's, first of all, the doctor can decide not to give a treatment because the doctor does have the power in terms of access to healthcare services. And the patient, of course, can always refuse to take a treatment. So what skills do clinicians need? And most clinicians will have had these skills at one time or another, but not all of them will be as competent in them as others. We certainly need to be able to listen very carefully. And I was taught is, don't say anything for the first minute, just listen. Don't jump in with any questions, because often the patient will reveal what's important as time goes on. Watch the patient, look for non-verbal clues, asking the right questions. There's a whole list of the sort of things that you need to be an effective listener if you're going to try and get a sense of what the patient needs and wants. And we've talked about how to talk about risk, which I think is a really difficult area for us when we communicate with patients. And look at the one at the bottom, because this is one that I think a lot of clinicians have difficulty. It's letting go of control. Clinicians are very used to being in control of the consultation. It's letting go and letting the patients take more control. It's about losing power. We talk about empowering patients. You can only empower patients if you're prepared to let go of some of that power as a clinician. What are the sort of questions we should be asking? We should be trying to get the idea with the patient that we are partners with patients, so that we're not doing things to or for patients, we're doing things with patients, and try to get an understanding. Again, we've probably all been taught this at some stage, but sometimes it's forget to do this, focusing that it's a partnership now and that we're doing things together. We're asking patients to ask 4 questions, to question the treatment when the clinician says this is what we'll do. And you've already seen those 4 questions or 5 questions, or in some countries it's 3 questions, but they're all broadly similar, saying, what are my options? What may happen? In addition, in Wales, we now ask this 4th question is, what can I do to help myself? We've heard about patient decision aids, and I'm going to quickly go through these next slides, because we've already seen some patient decision aids. We do know they help. There is research. But we need to recognize that they're different from what clinicians are used to dealing with. Clinicians are used to guidelines, too many guidelines for many. But look at the big items in blue, the differences between clinical guidelines and patient decision aids. One's orientated toward doctors, the other is orientated towards, or clinicians, sorry, and the other is more towards a shared focus and making sure that the patient or consumer understands. There's a lot that's common between them, as you can see on that slide. But the guidelines make recommendation largely based on the values and what's important to clinical experts, although we're getting clinical generalists to get involved in NICE guidelines in the UK. A patient decision aid does not make recommendations. It just gives the choices and the options, and then it's up to the clinician and patient to decide which to take. There are standards for these. They do need to be presented in the correct manner, as we've just heard. They need to be understandable. There's a real danger that the more articulate and the more literate consumers and patients will access this better than those perhaps who have difficulty. Really interesting in the Welsh campaign, we've got a group of people with learning disability who are really, really keen to engage. And that's often a quite marginalised group in healthcare who don't get asked for their opinion. There is evidence that patient decision aids do make a difference. They do empower and help patients to make decisions based on evidence with greater knowledge. There is work that they're happy with the choice. What is often lacking is whether they produce better long-term outcomes for the patients. I think that'd be interesting work to pursue. There's some on antibiotic use, orthopedic use. It's also very important that we try and get rid of words. What we're hearing in the UK is we need to minimize the use of words and make much greater use of pictures, and specifically use sort of infographics like this. Then you can use them more widely. You don't have people looking at the picture and seeing a white man talking to a clinician when actually your population out there is black women, and people say, well, that doesn't fit me. So this is an example. It's not perfect by any means of one of our decision aids that we're using. And there are various other options. So we're focusing on advanced cancer, particularly in Wales. This is what we're asking clinicians. Don't assume, if you look in the middle, all possible treatment is wanted. Equally, don't assume that people don't want any treatment at all. Don't assume that you as the clinician have all the answers. A lot of the answers come from the patients. So consider, so we're not saying don't do advanced chemotherapy. We're particularly interested in using a fourth chemotherapeutic agent in stage 4 cancer. So that's people with cancer where it is really no longer possible to alter the course of the cancer. And yet oncologists are still saying, oh, don't worry, if this doesn't work, I've got another chemotherapeutic agent. And if that doesn't work, I've got another one. Actually, once you've had 3, the chances of benefit of a 4th one is very, very small. So we're encouraging clinicians to start having conversations around that particular area. So what's success? Success will be when patients are able to come up with these statements once they've had their interaction with the clinician, that they feel involved, they feel informed, they've been helped to make the decision, and the decision was based on what's important to them. And for clinicians to be able to say, I have been a professional, I've used guidelines, but I've not been directed by guidelines. I've used evidence, but I've applied that evidence to my individual. I've had those conversations with the patient. I've found out what's important to them. We've looked at these options together as a couple, and I'm only doing tests or treatments that I think are more likely to benefit the patient than risk harm. We can't do it all the time. Of course we can't. We're busy. Both patients and clinicians are very busy. Sometimes there won't be time for the conversations. But if we do it in 10% more of the conversations already happen, that's 10% of people who are probably making a better decision. So we cannot be perfect, but I think we can be a little bit better than good enough. Grazie.